evening. Today I'm going to talk about the prosthetic part over the basal implant. After we do the implant, we have to make sure that these implants are parallel to each other. So we start by doing the bending. In this stage, still we don't adjust or shape the implant. We keep it as it is. Just we do the proper alignment by doing the bending. If we want to do some shaping of the implant, we do it in the time of metal trial. So we keep doing the bending until the implants are almost parallel. You know these implants are easily they are bendable because they have a thin neck, so it can be bent to the proper alignment that it's supposed to be. So after that, we start putting the patient into centric relation. Here in this case, we don't have teeth, so we don't use centric occlusion, which is related to the teeth and maximum intercuspation. In our case, or what we do in immediate loading, that we do almost always full arches, so we don't have teeth, so we rely on centric relation. Centric relation, we have to put the condyle in the most superior, most anterior position in the glenoid fossa, and the condyle will articulate in the thinnest part, which is avascular, where we can receive load without any harm for the patient, since it is not innervated. There is no nerves there, so there will not be any pain in the occlusion. When the condyle are in centric relation, they can rotate in a fixed axis. Okay, so wherever we take the bite, it's still in centric relation. And also, if we want to adjust the vertical dimension, or we want to increase little bit or decrease, still there will be a minimal error, since we took it and made it in centric relation. So before taking the impression, we have to put the impression cap. These impression caps, it will be fixed. If it's mobile, we can use the flowable composite okay, we can fix these impression caps with flowable composite to secure it in place, in order that we can take the impression without they will fall while we are taking the impression. Okay, we discussed also about impression in a previous lecture, and what kind of impressions do we use. Actually, we recommend the additional silicone. Okay. Then we give to the lab the implant analogs. They will put it inside the impression, and they will bore it with a gypsum, and they can use also some kind of gingival mask to know where the gum is. Now, when we will take the bite, we have to make sure that we will transfer this bite and the relation of the maxilla to the skull. We can transfer that relation to the articulator, and we can do that using the face paw. Okay, when we use the face paw, it will take the relation of the maxilla to the skull, and we can have the same relation on the articulator. And this articulator also, it should be a semi-adjustable articulator, that it will mimic the opening and closing of the patient, because the ordinary articulator, it will just open in a fixed axis, but the patient, first they will have rotation of the condyle in the first, when opening almost half of the way of the mouth. Then when they will open full mouth, the condyle will slide. So there are different movements of the condyle, rotation and sliding. And this we can do it on the semi-adjustable articulator, so we can have the same bite as in the patient mouth. So also we can use these values. We can adjust the joint slopes of this semi-adjustable articulator 30 between 25 and 33 according to how we can see it on the patient. Okay, then we provide the lab technicians with the burn-out caps. These burn-out caps, they can put it over the impression analog in order that instead of they will do the wax button, it's already done. They can use these as a wax for specially made for that kind of apartment. Just they will have to connect it with the wax, and that's the wax can be exactly to the finish line as it's supposed to be. Then it will be taken for the casting. We can connect this wax button with resin. This button resin, also the button resin, we can cover it with little wax. This to make sure that there will be no shrinkage while casting. Now for the plane of occlusions, we have to respect the plane of occlusions. It's very, very important. This the relation of the teeth, the inclinations. We use the curve of speed, the curve of foot, sure that we give space to the tongue. We have to make sure also that we will not impinge the buccinator muscles and food will not be accumulated. And also it's good for aesthetics, phonetics. So we have to do this properly, and we should also the lab technicians will know how to do it and what the function of each. First, we have the curve of speed. If we connect a line between the tip of the canine with the anterior, with the buccal cusps of the posterior teeth going toward the condyle, this will give the curve of speed, and this is very important because curve of speed, if it will make sure that the closure of the arch, that it will be the forces, it will be in the wrong axis of the teeth. When going posteriorly, there will be a mesial drift, and this is to make sure that when the arch closes, that the forces, it will be aligned with the long axis of the teeth. Also, what will happen of the the curve of speed, if it's too concave or high posteriorly, this will make interference between the posterior teeth movement, and this will inactivate the muscles or make coordination of the muscle not proper, and this will lead to excessive forces on the posterior teeth, and this is not recommended in our type of implant and occlusion, because as our implant is freshly placed in the bone, we have to make sure that all the forces introduced to these implants are intrusive forces. We don't encourage extrusive forces. So if we put excessive forces on the posterior, this will make the anterior to have extrusive. It's going to pull it out. So we actually do our occlusion on the 4, 5, and part from the 6. We don't do it on the 7. So that to make sure that all the forces are pushing to the inside. They are encouraging that no extrusive forces. So we have the curve of Wilson. It is a mediolateral curve, so it's side to side. So we have the posterior teeth of the lower are inclined to the inside, and the upper are a little bit to the outside. Actually, in our type of occlusions over the immediate loading, what we do, we encourage that the curve of Wilson, it will be into 0, because we are using the cusp. We don't have inclination in the cusp. We have minimal height of cusp. So that's why we accept it as 0 inclination for the curve of Wilson. And our way of doing the occlusions, also we avoid the anterior guidance. We only rely on posterior guidance, which is come from the condylar or articular eminence. Also in Christensen's phenomenon, that there should be relaxing, or there will do disengagement of the posterior teeth while the anterior teeth are in anterior guidance, we can compensate for that with the posterior guidance. Also, we do it using also the Thurman way, that when he divides to balance the occlusion. We have in one side that we have the condylar guidance with the incisal guidance, and in the other side we have the cusp heights, we have the compensatory curves and the occlusal planes. Actually, for the incisal guidance, we usually don't have overjet. We don't have overbite, it's 0, and the overjet it's 2 to 2.5. So they don't touch the anterior teeth. So as I said, we rely on the condylar guidance. On the other hand, the cuspal, or the height of the cusp, are minimal for us. We have very short cusp with the inclination are minimal. So we have our bite on a flat surface. That's why this will compensate and will give chance for also the muscles to relax while we are doing the condylar guidance or the posterior guidance. The different occlusions, actually, there are occlusions for certain type of restorations you are making. If we are doing a complete dentures, we do a balance occlusion. We want all the teeth to touch in all kind of movements, so to retain the denture in its place. When we do the fixed bridge, we do the mutually protected occlusions, that we want to do the anterior guidance and protect the posterior teeth. But in our case, we do lingualized occlusion, and it has its own way of doing it, and its characteristics and principles we have to follow. So we don't, if we don't follow these principles, something might happen in the stability, this chain of things we are doing. If it will be break, it might affect something. So something might have to give in order to accommodate for the change that happened. Maybe you will have something in the attrition or in the periodontal ligaments, that there will be bone resorption also, or in the muscle soreness, or in the TMJ dysfunction. So we have to make sure that we're following the rules, so that everything will go solid and as it's supposed to be. So for our treatment plan, that also the lab technician should be also be aware of, that when we give the occlusion, 6 chewing units in each side, okay, of the jaw, and the premolars and molars width will not exceed 6 millimeters. Also the masticatory arches being equally, so we don't, it's supposed to be in the same, we give here up to 6, we give here up to 6, the same length. Also the AFMB angle, the angle which the patient chew, it should be the same. The functional angle of planus, okay, that in the functional masticatory angle of planus, that means it's that when he chew on one side, the angles should be the same, not steep on one side, shallow on the other side. No, it's supposed to be the same, so that the patient will not prefer a side over another side. If it's too steep on one side, it's difficult for him to eat in that side. He will feel more relaxed on the shallower angle, so he will prefer to eat on one side. We have to encourage the patient to have bilateral mastication, so we give the same angles. We watch the patient chewing, and if there is interfering and something making the angle more, we have to reduce it, and so to make the angles in both sides, it will be the same. So also we said that we give the occlusion, it's supposed to be on the lingual cusp. Okay, for the upper, it's in the lingual cusp, that's lingualized occlusion. It will be on the first premolar, second premolar, and this will ensure that all the forces, as I said, it will be intrusive forces, not in the anterior. If we give it on the anterior, it will encourage extrusive forces from the posterior. and vice versa. If we put it on the posterior, it will make extrusive forces on the posterior. That's why we said our implants are freshly placed in the bone, so we have to treat it in a way different than the other implants. So some doctors, they do try to do the basal implant, but they apply the rule that they apply it on any kind of restoration they will do. They will not stick to our rules, and the outcome, it will be compromised. And this, then they will start to blame the system. No, if you want to take this system, take it as a whole. You will do the basal implant, okay, do it with the surgical principles. Also, you stick also to the prosthetic principles, which I mentioned. Also, we have the casts. It should be occlude on a flat surface, and there we will not use the slopes of the cast. It should be, as I said, on a flat surface. So we will not encourage the lateral forces. We want to always make sure that our forces is going along the long axis of the implant, and this will save, and we can control the forces that it is generated. When we put the teeth, we have to make sure that any occlusion on the posterior areas, it should be removed. Okay, if the cast that should be blocked out, we have to make the cast as short as possible. It's going and happening on a flat surface. So we follow the lingualized occlusion. We put the upper teeth and the posterior teeth should follow. Okay, making sure that all the biting going with the long axis of the implant within the polygon of the implants. And for the anterior teeth, as I said, there should be no contact in the anterior teeth, and there should be the over bite is 0, the over jet is 2 and more, maybe 2.5 acceptable. We should keep in mind that there are difference between the natural teeth and the teeth that we give in immediate loading. Okay, the non-immediate loading, they function in group. Okay, malocclusion, teeth malocclusion can be compensated, but for malocclusion will bring problems, and we have to make that the occlusion is always right. So we have to keep calling back the patient regular recalls to make sure that the occlusion is proper and where we put it and where it's supposed to be. For the natural teeth, non-vertical forces are well tolerated, but for the teeth, non-vertical forces are not tolerated, and it will make us problem in the implant, in the prosthesis over the basal implant. Natural teeth and anterior contact will not affect the posterior teeth, but in the teeth over the immediate loading bridge. For the natural teeth, the second molar is a major area for heavy occlusion, but in our implant or teeth, we suppose not to put any contact on the number 7 or the second molar. We have also to remember that the forces, the receptors in the periodontal ligaments will control the forces in natural teeth, but in these we don't have that periodontal tissues, and nothing will control the forces. So we have to make sure to follow these certain rules to control the excessive forces. There will be extraction and bone resorption. We know that the maxilla, there will be a centripetal resorption, that it will resorb from the outside, so it will get to become smaller as it atrophied, while the mandible is centrifugal. It will resorb from the inside, so it will seem to look, it's bigger the maxilla. So we will end up that this one, it's little bit, the maxilla is retruded and the mandible it's forward to with relation to the maxilla are inside, and the posterior and the mandibular implant are going to the outside. But when we put the teeth, we have to make sure that we are in the long axis. Still, we have to maintain the long axis. So, if there is no bone resorption, there will be no problem. Actually, they are aligned to each other. We can do it in an easier way. But if there is atrophy, we can see that the maxilla is small, the mandible is wide, and in this case, we have to make adjustment. We should follow the upper teeth. We should put the implant, when we put the implant, we put the occlusion as a standard. We don't follow the, see many cases, you can see how this discrepancy between the upper and the lower, which will make a challenge for the dental technician to put the teeth together. First rule, as we said, we have to make sure that our bite are within the polygon of the implants. If we say the implants are put in the sides, we draw a line around it, that's the polygon. If we go outside that polygon, it will make extra forces. No, we're supposed to be inside. So that's why this gray, the gray, it's the occlusal, the occlusal surface. But the green dots were supposed to be the occlusion itself. Like if we imagine a trampoline, if you will jump on the middle within the legs, within the polygon inside, it's stable, it will not move. But if we put an extension to that trampoline and you will jump on outside the polygon of the legs, then the trampoline will flip. The same what we do for our implant. We have to make sure that we are inside our polygons to have the forces, all intrusive forces, and it will not affect our implants. Maxilla will follow the mandible, and we extend it forward. That means we are already outside the polygon, and it will start to cause us problems. But so, like this bridge, we can see here that it's fine, it looks nice, but the biting is already outside the yellow line. This yellow line is drawn with the implants, so the biting is already outside. This will create a problem for us. So we have to instruct and guide our lab technicians and teach him the proper way, what you want exactly, and he has to follow and try to do that, so you will not have problem with the occlusion later and compromise the stability of the implant. Another example, you can see the line of the implant, and we can see that the occlusion, it's outside that line. It is the proper way we can do it, that we make extension for the lower to follow the upper, and this will make sure that we are inside the long axis, and the forces will be controlled. In this case, the wax up, for the technical abutments, the one in the back, we did not follow it. We follow the standard, we follow the upper, so the lower, the occlusion follow the upper, not the placement of the implant. See, this is when it's the metal, how it's supposed to be, that there will be extension going to the inside, so it will support the occlusion, that it will be on the standard way, not following the technical abutments, not the technical implants. Another metal, see how we did not follow the extension of the implants. Now we go and follow the occlusion, the right occlusion. Here you see the yellow line where the implants are, the blue line on the lower where the implants, lower implants, but we did not follow that. There will be the extension went inside to follow the upper implants. Okay, here is the line for the standard, the blue line for the standard occlusion, and here we can see the red line or the orange line if we followed the arch of the implant. We don't do that. We follow the extension. We follow the standard of the occlusion with the upper jaw. So now we are using this new way of doing the prosthesis. Now here, since in Jordan we have this technology that titanium is being milled using CAD/CAM. So because it's made with the CAD/CAM technology, so it's absolutely precise and accurate. This is a titanium framework which has been milled out of titanium using CAD/CAM technology. The framework is then layered by porcelain to get the final product. This for today, this is the way we're supposed to do our prosthetic over the basal implant. We should stick to these rules. We should teach it to our technicians, so he will understand what we want exactly. It's not it's not that we are doing this over ordinary teeth or implants. Our implants, as I said, it's